So this presentation I presented at the AICC in 2023. My name's Kathryn, I'm a genetic counsellor based in Leeds. My presentation was talking about some clinical cases when we shouldn't do a genetic test, but I actually took a little bit of creative license with that title and have decided to talk about when genetic testing is a little bit more complex. So to do that, I've used two cases that have recently been seen in our catchment. First one is family A, where we've done some genetic testing that's uncovered a phenotype positive, genotype negative individual in a family, and then family B, which was seen by one of my colleagues, and that's around predictive testing in a child with a pathogenic and variant of uncertain significance in the family. So both of these cases have been discussed at many multidisciplinary team meetings, and these discussions reflect our decisions at the time, but I appreciate other services may have a different approach, particularly around predictive testing in children, as I know that's a hot debate at the moment within the field. I've used pseudonyms throughout this presentation, and this is family A. So my patient was Sophie. She was referred to our service because her mum had an out-of-hospital arrest. Mum had a number of cardiac investigations and a number of genetic testing panels, and eventually had a diagnosis of ARVC. She had genetic testing for genes associated with long QT syndrome, ARVC, and also dilated cardiomyopathy, which eventually identified a DSP variant, which we thought fit her phenotype. So the advice at the time was given for her her relatives to present for predictive testing. And her children at the time were very young, so we offered them cardiac screening before any predictive testing was discussed once they were old enough to make an autonomous decision. So as you can see from the pedigree, a couple of people did present for predictive testing. Everyone we tested in this family so far had been positive. They'd had clinical screening alongside their predictive test, and at the moment no one had a clinical phenotype, even if they had the DSP variant. So Sophie and her siblings all had cardiac screening through their childhood. When Sophie reached the age of 17, she was referred to our service, and she had some phenotypic features of ARVC, so it was thought appropriate at that point to have a discussion around predictive testing. Sophie was quite upset about this discussion and found it quite difficult to comprehend that she may have a diagnosis of ARVC. When I saw her, I counselled her around the most likely chances that she would have the gene change, but also caveated that within some families it doesn't quite follow with what we expect. So to talk a little bit about Sophie's phenotype, her clinical screening showed that she met task force criteria. She had a major piece of criteria, which was the confirmed ARVC diagnosis in her first degree relative, and then she had two minor criteria based on her screening. So with that combination, that is considered a definite diagnosis of ARVC. And so we organised that predictive testing for her, which actually found she did not have the DSP variant. Now that's quite interesting, because if we take away the major criteria of her family history, she doesn't quite get a definite diagnosis of ARVC. As soon as we got that negative predictive test, I took this family to our multidisciplinary team meeting. And there was quite a few things that we were thinking about. We discussed whether there could have been a sample mix-up. Was there a labelling issue? Is the variant still considered pathogenic? Now, we thought both of these were quite a low likelihood, because usually when blood samples are taken, there's always 3 identifiers, and the variant does get reviewed as part of that predictive testing process within our laboratory. We'd also considered whether there was a second variant in the family that hadn't been identified on the previous genetic testing. Now the panels have changed slightly. And we also wondered whether Sophie had a completely novel variant that wasn't seen in anyone else in her family. We also talked about the need for further investigations to confirm Sophie's diagnosis of ARVC. So after that discussion, we decided to repeat Sophie's sample, or repeat the test on a fresh sample for Sophie. And that actually found that she definitely didn't have the DSP variant. We also decided to review the variant in a more formal basis. And again, that was definitely shown to be pathogenic, with a piece of moderate supporting and very strong evidence. We also decided that we'd repeat the current R132 panel on Sophie's mum. Again, only showed the DSP variant. It didn't show any other variants that would explain the phenotype. And then we decided to offer Sophie the testing and do that full panel on her, which didn't identify inherited or genetic cause for her presentation. And that repeated test on Sophie was done after some further investigations, and she definitely has a diagnosis of ARVC. So that's left us in a slightly difficult situation. At the moment, we have now completely paused predictive testing in this family because we can't be sure, we can't be reassuring based on a single predictive test for DSP, as there may be another variant in the family. So at the moment, we're keeping everybody under screening. And in this case, there hasn't been anyone tested negative for the variant, so everybody's already under screening. But this just shows a couple of complex issues around predictive testing when there's a phenotype positive patient where it may not necessarily be the gene that's in the family. So family B is seen by one of my colleagues, and Millie is a 12-year-old who's referred to our service because her parents want her to go forward and have predictive testing for MYBPC3 and MYH7, which are some variants that have been found in their family to cause hypertrophic cardiomyopathy. So the original proband is Millie's grandfather, who passed away from HCM. He was found to have both of these variants, and that testing was carried out a number of years ago. He had quite a severe phenotype of HCM, as does his daughter Stacey, who's Millie's mum, and Stacey has also been found to carry both of those variants in the family. When Stacey presented to us in clinic after the referral for Millie, she described that a lot of her family have been tested overseas and have been tested for both of these variants, and that they all seem to have both of those variants at this stage. Now, to add a bit of complexity to this family, another branch of the family not on this pedigree was seen in our clinic, and we offered them predictive testing for both variants, which led the lab to review these variants and actually downgrade the classification for the MYH7 variant to a variant of uncertain significance. So Stacey didn't know that at the original referral, but this was something that was explained to her in clinic. So Stacey described Millie as quite an anxious child, and the main reason that she wanted to have genetic testing was because she'd struggle around the anxiety of cardiac screening. We tried to explore this further because we also imagined that Millie could be quite anxious if she was found to have one of these variants, and know that she was at an increased risk of a genetic condition. We also explored why Stacey wanted testing for Millie, because this is not something that Millie was actually asking for, and so was doing a test taking away her autonomy. We also discussed with Stacey the fact that the MYH7 variant has now been downgraded to a VUS, and we also talked about the complexities around family members having different testing in different countries, because a lot of Stacey's relatives were actually overseas. So to give you a little bit of a background about the variant interpretation, the original testing was actually reported before the Richard et al. 2015 guidelines. So the first variant for MYBPC3 had the following evidence. So it was PVS1 as very strong because that variant is predicted to cause nonsense-mediated decay leading to a null allele, which is one of the mechanisms of disease with MYBPC3. PS4 moderate, and that's because this variant has been reported in the literature as within families with HCM and has also been seen in the laboratory within families with HCM as well. PPM1 moderate just shows that it's shown to segregate with disease in families, and PM2 shows that it's absent in controls as well. So that's the evidence that was applied for the MYBPC3, which showed that it was strongly pathogenic. For the MYH7 variant, that was reclassified from the testing pre-2015, and that had PS4 supporting evidence, which showed that it's a slightly increased prevalence in HCM patients compared to controls. The PP3 evidence is where multiple computational evidence is supporting that it's pathogenic, but then also BP3, which is a benign piece of evidence, was applied because it's been seen in patients with an alternative cause for their HCM in both the literature and within the laboratory, and that included this family in this case. So you're making it a cool VUS, and that was because it was previously classified as probably pathogenic in those pre-2015 guidelines. So things have changed quite a lot in the cardiac sphere with this variant classification. And there's an interesting paper by Wong et al. where they looked in their cohort of patients in Australia, where 36% of cardiac variants were reclassified based on that 2015 paper. So that is a huge number of variants that are being reclassified after 2015. So I think that's another really important thing that we need to be aware of if we're offering predictive testing to families where they've had some quite old genetic testing. Some of the discussions that we had at our MDT were thinking about how would we feel if we only tested Millie for the MYBPC3 variant. Is this something we would discharge her from clinical follow-up, even if we didn't know what her status was of having the VUS? We also thought about whether Millie actually wanted this information. She's 12 at this time, and she isn't actually asking for this information. It's just being led by her parents at this stage. We also wondered whether she would cope with a positive result or even the uncertainty around a VUS, and whether that's something that she could even comprehend at the age of 12. That's very complex information for a young person to understand and deal with. We also thought about her brother. She had a 6-year-old brother, and whether if we offered testing to Millie, is that something that we'd need to offer to him as well? He's even younger, so he'd have even less autonomy to be able to make that decision for himself. We also wondered whether our laboratory would even offer the testing for the VUS. Now it's been downgraded. So we had a lot of discussions around how would we manage this family and what would we offer. We decided that we would offer testing for both of those variants because if Millie had neither variant, then we'd be able to discharge her from screening. And this decision was made based on some of the feedback we had from other genetic counsellors in the country as well, because that was taken to a national meeting where we discussed that too. Interestingly, my colleagues had discussions with the family, and they decided that they was going to delay some genetic testing and revisit that at the children's next cardiac screening appointment. So at the moment, Millie is on annual screening, but her brother potentially wouldn't need screening for a couple of years. So it just shows the importance of being able to speak to patients and go through all this very complex information, because this family originally came in very strong that they wanted predictive testing for both of the variants, even after we explained that one was a VUS. And to go from that to then delay a decision around genetic testing just shows how much families value this information and how important that is in their decision making. So it's really important to have good genetic counselling with these families, even if it's a relatively straightforward test. The implications around that are really important to convey to those families. Just put a page of acknowledgements. These cases have been a very multidisciplinary team case. So I just wanted to acknowledge all of my colleagues that have been involved with those decisions.